Go further with the American Express Business Gold Card. Earn 3 times membership rewards points on flights and prepaid hotels when you book through AmexTravel.com. Whether your destination is a business conference or a client meeting, your purchases will help you earn more points for future trips. Experience more on your travels with Amex Business Gold. Terms apply. Learn more at americanexpress.com/business-gold. Amex Business Gold Card. Built for business by American Express.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies. And today we're going to talk about preterm labor. I know that can sound like a scary, maybe even overwhelming conversation to have, but it's so important to understand the risk factors and then also what you can do if you do have some of these risk factors. I know I had a little scare in my first pregnancy where I felt a little crampy and I got really worried it was preterm labor. It turned out I was just dehydrated, but it did scare me and make me realize, do I understand what I'm looking for in terms of preterm labor? So we are going to cover in this conversation about the reevaluation of progesterone, what it means for patients and providers. We're going to talk about the preterm risk factors and then what you can do about that, lifestyle, environmental contributors to preterm birth, as well as racial and socioeconomic disparities and why they persist. So to have this conversation, I have Dr. Laura Jelliffe-Pawlowski. Let me tell you a little bit about her. So she is professor of epidemiology and precision health at NYU Rory Myers College of Nursing. She founded and led the International Hope and Research Consortium and is the primary investigator of the Hope, Prompt, and Thrive studies. Her work focuses on identifying causes and prevention strategies for preterm birth and adverse pregnancy outcomes. And she has published over 150 scientific papers and was named to Forbes 50 over 50 list in 2023. What I love about this conversation is I feel like Dr. Jelliffe-Pawlowski gives really solid understandings, signs and symptoms of preterm birth, and then what you can do about it. And reassurance that if you do have some of the factors, there's things that you and your care provider can work together and to help you and your baby have a safe and healthy pregnancy. And she really does, I believe, help put the mind at ease because pregnancy is filled with anxiety. So why add something else? This can be more about feeling empowered to help the health of you and your baby. I'm excited for you to hear this conversation. Now, before we get to this conversation, let's talk about what's happening at Prenatal Yoga Center. So as I always mention, check out our website, prenatalyogacenter.com. That's going to give you the latest on our classes, our in-person, our online, our on-demand classes, as well as our workshops and our yoga teacher trainings. There you can also find years of blogs, as well as some of our older podcast episodes and the application to be on the podcast. What's been really fun is I've had people that have listened to the podcast and said, I want to share my birth story too, or I have a great idea for a podcast that you haven't covered. I love when I hear from you, the community, about what you want or what you want to share. So keep that going. And besides the application on the website, you can always reach me at deb@prenatalyogacenter.com because I really do want to hear from you. I would also ask you, our listener, our community, the favor of leaving a rating and review. It helps people find the podcast. And I love doing this podcast to help build confidence and support and community during pregnancy and early postpartum. So the wider we can cast our net and bring people into the community, I think the better for everyone. So please leave a rating and review. All right, I think that's enough from me. We're going to take a super quick break. And when we come back, please enjoy my conversation with Dr. Laura Jelliffe-Pawlowski.
Gold Bond knows that things are just better with a little boost. Like your music? And your skin. Check out Gold Bond's new Plumping Collagen Body and Face Serum Lotion. It's clinically shown to visibly plump and boost skin hydration by 50%, leaving your skin looking hydrated and more youthful. Turn up beautiful skin with Gold Bond's new Plumping Collagen Body and Face Serum Lotion. Learn more on Amazon.
Hi, Dr. Jelliffe-Pawlowski. How are you?
I'm good. Cold. It's getting a little warmer, though, in New York, which is nice.
Yeah, I know. I was looking out and I'm like, yay, the snow is melting. That makes me so happy.
I know.
So I'm excited to chat with you. We're going to talk about preterm labor. I know in my own pregnancies, there was a certain point where I was like, all right, we're in the clear. And then I know that also for other students feel that. So I'm excited to dive into this topic. So let's start with, why don't you share a little bit about yourself and what led you to your research on preterm birth?
So I am a researcher. I've been doing work on investigating sort of pregnancy in general and newborn outcomes, and have been doing that for about 10 years. And then the most important thing in my life happened to me, which is I delivered preterm. So I always say to people, I am a researcher, an academician, but most importantly, I'm the mom of a daughter who was born prematurely after I had preeclampsia and had a pretty scary birthing experience.
Wow.
So that really, after that happened to me, I'm sort of a rare breed in that I am mostly focused on research related to preterm birth.
So were you already doing research work and then you had your preterm baby, or was that kind of what jumped you into this topic?
I had done quite a bit, the related to preterm birth, because when you're researching sort of poor pregnancy outcomes or even chromosomal abnormalities and things like that, preterm birth kind of oversects with those things so often. But no, I was very much kind of researching in this space before I had my daughter prematurely. But preterm birth happens to about 1 in 10 of every pregnant people. So it's quite common. So it's not a surprise that it happened to me.
Right.
It just, I knew the things I needed to do once things went south. So that really was a blessing for me and really changed sort of how I approached my career, in that, I wanted everybody to have the opportunity to know what to look out for, and even if they did start to have difficulty, to know how to respond.
Oh, I love that you have kind of a personal stake in this. I feel the same way with my approach to yoga. After a really hard first birth, I really dedicated to trying to help people have smoother births. So I think when we have our own experience, it just adds an extra layer of commitment. So let's start to talk a little bit about understanding preterm birth. So what has shifted in the last, decade about our understanding of preterm birth?
Oh, I would like to say that we've learned a lot, but I will say we've spent a lot of money.
Okay.
So we've spent, in many ways, billions of dollars. Now you say, gosh, billions of dollars? Well, we've put probably about $1.5 billion into research, but, it does cost annually in the U.S. alone about $25 billion to care for individuals born preterm, the people that birth them, and sort of long-term consequences of preterm birth. But we've made so little progress in better understanding it and reducing risk. The one place in prematurity where we have made really substantial strides is in keeping babies who were born preterm alive, right? So we do a lot better job now than we used to. And there's controversies in this space for sure, but we do a lot better job now in terms of helping babies born preterm survive.
What are some of the controversies?
Well, the earlier you keep a baby born preterm alive, the increased risk they have for having longer term neurological and psychological and growth and physical difficulties. So, for instance, it used to be if you had a baby born preterm at, 22 or 23 weeks, there may not have been as much effort to revive the baby and keep the baby alive. But now sort of everything happens to really make sure that even sometimes down as low as 20 weeks, that you're doing everything that you can to keep that baby alive. And with that comes some substantially increased risk for things like cerebral palsy and other difficulties. So that's kind of the controversy, right?
That makes sense. So let's talk a little bit about prevention. I'd love to hear your thoughts on that, because I'm sure my listeners are very interested in this, because if they click to listen to preterm, they're probably thinking, all right, how do I prevent this? What does the latest evidence actually support, and where are we still uncertain?
So, that this is actually a place that my career and my research has taken kind of a big turn over the past 2, 3, 4 years. But, even more recently, we did one of the largest studies that was done in the world during the pandemic. It was called HOPE, the HOPE COVID-19 study. And we enrolled about 500 people around the world into the study during the pandemic. And one of the things that kept coming up when we would connect with pregnant people were the number of individuals who might have had a diagnosed condition for which there's a solid kind of evidence-based intervention that may help them not only with that factor, but reduce their risk for preterm birth, but for which sometimes pregnant people didn't know about it, or sometimes they might know about it, but for whatever reason were not there was not the uptake in the intervention. One of the things, and there's just many, many examples of that. So, for example, we know that aspirin in pregnancy can really help a number of people not only reduce their risk for preeclampsia, but also reduce their risk for preterm birth. But we know that only about 30% of people who may be qualified for it, or it may be a good idea, take it. Right? Same thing with, say, asthma and corticosteroid inhalers. Only about 30% of people who have asthma and would benefit from a corticosteroid inhaler are getting it. Same thing with mental health conditions and different therapies, which may just be in-person therapy or some pregnancy-safe medication. So over and over, there are all these examples of things that we know may be helpful to pregnant people, but for which uptake is quite low. And once I really became aware of all of these different conditions that I know very well from my own research are so highly associated with preterm birth, and the low uptake in interventions, we really started to pivot into like understanding why those uptake rates are low, and trying to address it as a way in which we can think about intervention from the lens of action, right? So years ago, we created a blood test, for example, that can identify people at much increased risk for preterm birth. And what we heard from working with community members and even physicians was, well, people, thank you for the information. It's good to know. I need to be aware of potential symptoms, but what can I do about it? People want to know, but they want to have action. And so we've really changed what we're doing to focus on that actionable piece, right? So,
is the blood test something people are regularly offered and getting?
No, at that, there are blood tests out there through other companies like Sarah Prognostics where you can identify people who are at increased risk. And we actually just went to patent on an additional blood test to be used in combination with understanding people's actionable risk. But there now are a kind of a number of different blood tests out there, but the trick there is, okay, great, somebody's increased risk. What are you going to do about it, right? So the uptake in those blood tests has been quite low, which is, one of the many reasons we've pivoted to really focusing on action, because we hear this from pregnant people and we hear this from providers. People want to know what to do about it. And I think for a while we were thinking about, maybe there's something novel we can do about it, not just being aware of early symptoms of preterm birth, which are really important. But when we started digging into the literature around, all of these evidence-based therapies that are currently not being used and understanding why that is and in what populations, and understanding that better is sort of, to me, feels like the place we need to start.
Oh gosh, I have so many questions. And even though I know I have written questions, I feel like what you just said has other questions I want to go off.
Exactly.
So, all right. So what I'm understanding is someone may be at risk, but then are there actionable steps? Like, what do they do if someone is assessed for being at risk? And I guess we can also kind of throw in there, like, what are the factors that they should be assessed? Because it sounds like not everyone's being assessed for it. So I'm going to throw all that at you.
Yeah, no, it's fine. It's a long list of things. And, I should mention, and I'm quite proud, for when we did our blood test, for example, we went out and, we went to all these labs who wanted to, talk about whether or not they would license the test. And because the research that led to the blood test many years ago came from the Bill and Melinda Gates Foundation, who require before you license it out that it may be made available in low-income settings. It time and time again, they were not that interested in sort of tests that would be sort of rolled out into lower income settings. They were much more interested in sort of insurance and that kind of thing. But that caused me to really think about how to get these things out in the market. And my husband and I started a company that's called Egg Healthy Pregnancy. That's all about how do we take these new tests and tools and technologies and kind of get them into the hands of people that need them. And two things, there certainly are individuals who don't have any risk factors for preterm birth who start to experience signs and symptoms of premature labor. And that's one group. But the vast majority of people who have a preterm birth have other risk factors. Right. So we want people, and what we've been working through Egg, and we've created an application that's called Natalie that allows people in about 5 minutes to really take a questionnaire to better understand their risk factors. And then it really comes back and talks about the kind of therapies that may be helpful to them, and creates a report and something that they can use with their providers. And so we have a lot of hope that tool will ultimately lead to better uptake of interventions and then ultimately reduce the risk of preterm birth. But there's a lot of the factors. So there are 16 factors that have been shown in many, many studies around the world to consistently be associated with preterm birth before 20 weeks, and another 2 that show up after 20 weeks. And people are not even aware of them. Physicians are always aware of them and the implications. And they're very, very basic things like asthma, anemia, of course, smoking, alcohol use, having a mental health condition, having a history of cancer or lung disease or immune disease. So all of these things are associated with increased risk and all have therapies associated with them. So we are very focused on sort of understanding a person's risk and making sure that they have the information that they need at their hands to understand their own pregnancy health. And honestly, I did a talk some years ago with trusting pregnant people with their own pregnancy-related information. There still can sometimes be this feeling like we have to protect people from information about their own health, and that is just not something that we do anymore. We really believe strongly as a company, as an individual, that people have a right to their own health information, and that's kind of the business that we're in. And I feel like if we better trust people with information about their own health and their own bodies, that they, of course, are in a position to make the decisions that they feel are best for them.
So where can people find this full 16 factor, the full list of the 16 factors? You mentioned about 5 or 6. And yeah. I just feel I'm confident that if I was, a pregnant listener, I'd be like, I want to know all the factors. And some.
We just published in open access an early view of what's called the Actionable Risk Index, and so I will make sure that you have that so that you can share.
I would love that because some of them sound like you can do something about them.
They all are. All 16 are things you can do things about. That's what we focused on. A good example are, some of the risk tests that are out there that show whether you're at risk. They'll say, what's your age, what's your race, ethnicity, what's your pregnancy history. Those are all really important factors, but when you look at them individually, it's unclear, like, what's the action. But what we know from clinical guidelines, for example, is if you have 2 or more of those, you're at increased risk for preeclampsia, and that they suggest that you consider taking low-dose aspirin starting after the 12th week of gestation. A lot of people don't know that, right? Or their physician may mention it in passing, but not talk about, because you have these factors, there is some information, some data shows that taking a low-dose aspirin can increase the blood flow to the baby, open up the vasculature for the placenta, and really help with growth and development, right? I've talked to dozens and dozens of pregnant people about aspirin, for example. When you put it to people that way, people are like, oh, I get it, right? But what you can't say to people is, you're pregnant, I think you should take an aspirin because of your race, ethnicity, and the fact that you had a previous preterm birth. People will be like, that makes no sense to me, right? You have to trust people with information like aspirin may help with blood flow and oxygen to the baby, open up the vasculature to the placenta. People are like, okay, I get it. I'm in. I can do that, right? They're not going to just... In many cases, just because somebody told them they have to take an aspirin because they're pregnant, especially if they're individuals who are very cautious about taking medications while pregnant, that's not something that they may really want to do, right?
I actually appreciate that. We actually, in both our teacher training and our classes, we are really big on the why. Like, if your care provider says, I want you to do this, just ask, okay, but why? Because then you can make informed decisions. I'm really big on the informed decisions.
Same with, corticosteroids for asthma. Mm-hmm. That sounds scary. It's a steroid, right? So sometimes you have people who have very severe asthma who become pregnant and choose not to continue with their inhaler, right? And when you're pregnant, it's especially important that you take your inhaler if that's something that you have been doing, or if you develop asthma. It's very much a safe medication for baby. It's really absorbed through the lungs of the mom and can really open up that oxygen flow to the baby. So you want that. You absolutely want to have enough oxygen in them, but people are afraid. And then, one of the other factors that you'll be able to read about that's common that a lot of people don't know about is how important sleep is during pregnancy. Mm-hmm. So insomnia and having any problem with breathing while you're sleeping is an important risk factor for preterm birth. And, if your partner is saying to you, if you notice you're not sleeping well, or your partner is saying to you that you're snoring, going in and having a sleep test, it may not even require a medication. It may be a CPAP machine or something that can help you sleep better. These kind of conversations are super important, but often are not happening for whatever reason. It's just such an important conversation to be had. And for whatever reason, so many of those conversations aren't happening. And so we're really working to,
I actually appreciate you saying here are 16 factors and here are some ways to prevent it. I actually want to talk about progesterone. We're going to take a quick break. When we come back, let's actually talk about progesterone and its role in prevention. All right, we will be right back.
Eczema is unpredictable, but you can flare less with Ebglyss, a once-monthly treatment for moderate to severe eczema. After an initial 4-month or longer dosing phase, about 4 in 10 people taking Ebglyss achieved itch relief and clear or almost clear skin at 16 weeks. And most of those people maintain skin that's still more clear at 1 year with monthly dosing.
Ebglyss, lebrikizumab LBKZ, a 250 milligram per 2 milliliter injection, is a prescription medicine used to treat adults and children 12 years of age and older who weigh at least 88 pounds or 40 kilograms with moderate to severe eczema, also called atopic dermatitis, that is not well controlled with prescription therapies used on the skin or topicals, or who cannot use topical therapies. Ebglyss can be used with or without topical corticosteroids. Don't use if you're allergic to Ebglyss. Allergic reactions can occur that can be severe. Eye problems can occur. Tell your doctor if you have new or worsening eye problems. You should not receive a live vaccine when treated with Ebglyss. Before starting Ebglyss, tell your doctor if you have a parasitic infection.
Ask your doctor about Ebglyss and visit ebglyss.lilly.com or call 1-800-LILY-RX or 1-800-545-5979.
K-pop Demon Hunters Haja Boys breakfast meal and Huntrix meal have just dropped at McDonald's. They're calling this a battle for the fans. What do you say to that, Rumi?
It's not a battle. So glad the Saja Boys could take breakfast and give our meal the rest of the day.
It is an honor to share.
No, it's our honor.
It is our larger honor.
No, really. Stop.
You can really feel the respect in this battle. Pick a meal to pick a side.
Ba-da-ba-ba-ba. At participating McDonald's while supplies last.
Okay, we are back. So let's talk about progesterone. I know that friends that have done IVF talk a lot about progesterone there. So let's talk about its role in prevention for preterm labor. I'm just going to hand that off. What would you like to say about that?
Well, progesterone is one of these really interesting things in that it used to be, for instance, that if you had a history of preterm birth, they'd have you take progesterone, or if you were falling in a category of being increased risk for preeclampsia, they might have you do progesterone and aspirin. Those guidelines really changed a couple of years ago, where they started to look at the studies and found that everybody getting progesterone really wasn't, if you didn't need it, it wasn't making a big difference or any difference sometimes. So it's become much more personalized, like depending on your specific risk factors. And so now we know, for instance, if you have a previous preterm birth and your cervix is getting smaller, cervical shortening, that's the group you want to make sure gets progesterone. So it's no longer like everybody should get progesterone. It's really people who have had this previous preterm birth and have this cervical shortening. Sometimes they'll do the screen of the surgical shortening and they will prescribe it even perhaps if you haven't had the previous preterm birth. But that cervical shortening is really important. That's the one that says, okay, you're showing some signs of preterm labor. Now, what we do for Natalie, the questionnaire, et cetera, we're very much focused on way earlier than that, right? We want to give people action and information that comes way before then. So that's very important. We need to do that. We need to continue those screenings, especially if somebody has had a preterm birth before. But the question is, what can we do way ahead of that? Not only in terms of addressing existing risk factors, but also making sure that all people, again, if you have no risk factors, you still have about a 1 in 15, 1 in 20 chance of delivering prematurely. So you still kind of need to know, right? If you start to feel lower pain, any signs of preterm labor, to make sure to go in and get care, because, even all the way up until that, the actual preterm birth, there are really important things that can happen. For instance, in the hospital, you can be giving steroids to help kind of increase the maturity of the baby's lungs very quickly so they're able to breathe more. There are medications that can be given to mom that get into the baby's brain that can help decrease the likelihood that a baby will have brain injury. So we still want to make sure. So that's also a piece, not only the interventions early, but don't wait, right? If it's feeling like something isn't right to you, go get care so that even if the baby is born early, that they can still do things that can really help baby development. So,
let's talk timeline a little bit, because I know that due date is, one thing, but then, so I'm also a childbirth educator, and we were always told 37 to 40 weeks is or plus 40 plus weeks is what we call the birth window. And so I've had people be like, oh, I birthed early. I birthed at 38 weeks. I'm like, that's not really, it's earlier than you were expecting, but I wouldn't put that necessarily in preterm. So can you give a timeline of what is very preterm, kind of, I don't know if there's moderate or like within the birth window, where, when we say that, what's that whole spectrum look like?
So early preterm birth, we usually think about as being less than 32 weeks, right?
Okay.
And then late preterm birth is 32 to 36 weeks. And then there's this other window, which is called early term. And those are your 37 to 38 weekers. And we know that 37 to 38 weekers can still have more difficulties than, say, those that make it to that 39 to 42 week window, which is one of the reasons why they now don't induce as early as they used to. You know, there used to be something, oh, you hit 37, we can induce you. They still do that sometimes, but they really want to give babies every week that they possibly can. And it's our team that did some of that research on those 37 and 38 weekers who are called the early term babies. So it's important to remember that is still early,
right?
Earlier than that we would like.
But you wouldn't necessarily call them like, so it's early, it's in the window, it's just earlier in the window, but would they necessarily be like in the NICU preterm birth?
See, that's what's in. Those are called the early term babies, right? And those early term babies are more likely than babies
to still be in the NICU.
Exactly.
Oh, it's so interesting. Okay.
So those, that's just one of those kind of common misconceptions, right?
Yeah. No, thank you.
And it required the research to say, so it really, now again, nothing compared to what we see for the babies born less than 32 or even the 36 weeks. But it's important to remember, like, those last weeks, that's where all your growth happens, right? So you can still be at like those 37 and 38 weekers. They come out, but they will often be smaller than they were expected. They are more apt to have sort of asthma in later life. They are not yet able. So we want to get every single baby we can to kind of that 39-week mark.
All right, when I ask a statistic question, I'm literally just throwing at you. I did not prep you for this. So do you have so there's probably the bell-shaped curve. Like, what are the statistics? Like, how often are you seeing like very early, like 20 to 30 week, and then like 30 or 32 to like 36? Like, where do people typically, what are the statistics of people falling in those categories?
Yeah, you really are putting me on.
I am. And you can be like, Deb, I don't know, which is totally fine.
I usually think about it. I'd have to look at it, but it's usually about 2 to 3% of births are going to be in that less than 32 week window. And then, around, 7 to 8% in that 32 to 36 week window.
That's helpful. And I know I'm totally throwing that at you. And the only reason I want to see, because some people work well with like, okay, 2 to 3%, that's probably not me. And so I think it can just help people's anxiety a little bit.
Yeah. And I think that that's a really good word, right? Anxiety, because I think there's a lot to unpack there, right? And again, we've talked with so many pregnant people around this topic for so long there is so much, controversy, I will say, within the clinical field about how much information about risk for preterm birth you should share with pregnant people. And that just kind of kills me, because I'm like, share with pregnant people about their own health, So, but having said that, so we even did sort of some qualitative work where we asked pregnant people about this question, like, would you want to know, right? And not everybody did, and that's important to remember, right? But the vast majority did. So, about 80 to 90% of people, we said, if you knew you were at increased risk for preterm birth, would you want to know that? And there were definitely some people who are like, I don't want to know. That scares me. That's just going to make it worse. But most people want to know. But that's also different than what we hear from many clinicians who are more reluctant sometimes to talk about risk with pregnant people because they feel like they don't want to stress them out. And so it's like understanding, like, people often will know that something's wrong. You're not often protecting them, right? Having open, honest conversations. And what we've really, I think, pivoted to is really focusing on the actionable risk factors, right? So once you decide we're going to focus on the actionable risk factors, it feels to me hugely ethically problemsome to not be having those conversations with pregnant people in a really honest and open and transparent way, right? A good example is our HOPE COVID-19 study, when we were talking about, one of the things that was a big surprise to me was, and for those of all of us that went through the pandemic, we're probably not surprised to hear this, but how common drinking was during pregnancy, right? Mm-hmm. We had about 30% of people who expressed that they were drinking during pregnancy. And how do you have those conversations in a way that doesn't feel judgmental. Right? Yeah. As opposed to just saying, I get it. I know it's stressful. There's a lot going on, but this is one of those areas where there's so much bad data. And the truth of the matter is no level of alcohol is safe. So it's important to, if you are having that one glass of wine once a day, once a week, once a month, to really think about that, and really try and get to that no alcohol. I had a friend who during pregnancy, and she is quite a wine connoisseur. I said, put a marble in a jar and know that that's $10 more per bottle of wine, so you can get a better one next time, right? So now you're getting the $200 bottle later on, but alcohol is one of those ones where it's really important to stick away from it if you possibly can. But there's so much, data all over the place. And the same thing with cannabis. There just isn't a safe level of use. But many people don't have that information, or people are not having those conversations, or many physicians may not even be asking because it's an uncomfortable conversation. But
I have a question about if people start to feel, you already said head to, talk to your care provider, maybe head to the hospital if they're feeling that. What happens? And some people I know could stay in the hospital for a while. What are your thoughts on staying on bed rest? And we've actually had some students with this, with the cerclage. I hate that word incompetent, or that phrase incompetent cervix. It makes you feel badly.
Yes, it
cervix.
does.
It's not a nice phrase. It's almost like failure to progress in labor, or, or failed induction, whatever. Yeah. Fail or incompetent are not nice. Yeah. But I'd love to know your thoughts on that, because I've had students that have been through that will come to class, will modify for them, but they'll be like, I have a cerclage in, it's coming out at 36, 37 weeks. And then some are like, my doctor's putting me on complete pelvic rest or bed rest. What are your thoughts on that?
So cerclage, so there are a couple of things. Once you start to really see leakage or movement of the cervix, that's usually the road to delivery is coming, right? That's sort of one of the indications. And data does show if you have the cerclage, so really 1 or 2 stitches in the cervix to kind of tighten things up, decrease the chances of to keep the fluid in, but also to really decrease the chances of going into labor, as soon as would happen without the cerclage. That data is really good, especially if you combine it with a tocolytic. So tocolytic is kind of like cerclage. It's trying to reduce the risk factors and the early signs of delivery. So tocolytics are going to be taken to kind of decrease the chances of having labor pains, going into that side of labor, and the cerclage is really to sort of tighten up the cervix, which is the other thing that obviously happens when you start to go into labor. So, that's the piece I was talking about, which is knowing that you're increased risk for preterm birth. Not only can you, there's action associated with, okay, maybe I should take aspirin, make sure that I'm getting the iron that I need because I might, if I have an anemia or addressing an issue I may have around sleep. It's also being aware of early signs of labor so that you can get things like a cerclage or tocolytic to help increase the likelihood that you can go one more day, one more week. I mean, that's what's most we think about when we're thinking about preterm birth. Is even one more day is huge. One more week, fantastic.
So
One
can
more
you
month,
specify
amazing.
specific patterns or signs that parents and providers should pay attention to for this early preterm labor and early intervention?
Well, I think so there's the signs of preterm labor, but it's more important, the CDC has, a lot of data on like early maternal warning signs. Everybody should know those. And so there are the signs that have to do with preterm labor that really have to do with, fluid leakage, feelings of pressure or contractions, those kinds of things. But even more important than that, when we move the clock backwards, are thinking about things like headaches. Blurred vision. Those are the things.
Preeclampsia, like things that could be indicators of preeclampsia.
Those are the things, people sometimes think of preeclampsia and preterm birth as kind of separate, and they are absolutely like all intertwined, right? And so being aware of those kinds of things, right? Blurry vision, headaches, water retention in your hands and your feet. Those are the kind of things that really can move people along the pathway to preterm birth through preeclampsia, right? Same with so our two biggest risk factors for preterm birth are always hypertension and diabetes. And so and when we say hypertension, diabetes, we mean hypertension, diabetes present before pregnancy or developing during pregnancy, right? So those are our two big ones. And so if we're talking about hypertension or diabetes present before pregnancy, hopefully you're already under the care of a physician, and that's a group that really likely have been counseled by their provider to start aspirin at 12 weeks, in addition to whatever other therapies that they're getting, right? So they may stop antihypertensive medication during pregnancy and add the aspirin. So, and then for those who develop hypertension or develop gestational diabetes during pregnancy, those are not really the aspirin folks. Those are people, if you have, for example, severe hypertension, there are some medications that can help you with that. You really need to be being seen by your provider. Gestational hypertension, really diet, exercise, glucose monitoring, those things can make a massive difference. And so that's where it's really important, for example, to be getting to your prenatal appointments, getting those things measured. I was in many ways lucky in that I knew so much about preterm birth and so much about preeclampsia that when I started to see some of those early signs and symptoms, I was able to kind of jump on them, right? Get myself to a provider, stop working, stay at home, monitor the urine, really be on top of it. And so I had so much privilege, right? I had the information, I had a job, I had somebody in my life who would support me as while I did those things. But a lot of people don't have those. People are so busy. Either maybe you're healthy and working so hard and you're like, oh, I always get headaches, right? And you don't go and have that checked. Or, you have, a job that doesn't allow you to take time off to go to the physician as much, right? So those are the people that are kind of falling through the cracks, right? By the time they show up, the preeclampsia is so far gone, or labor is so far progressed, that it almost feels just too late to do anything.
Well, let's actually jump. That actually makes me think about the racial and socioeconomic disparities that we see in preterm births. And it's been well documented.
Yeah.
So what does the data tell us about why these gaps persist? And I think you started to share some of that, like you mentioned you had the privilege to be able to do this. You had a partner, like you had the job situation that you could take off time to go to the doctor, and that's not always the case. So
Exactly.
I'd love just kind of open that question to you.
Yeah. So we know, for example, it's also really important. So Black individuals, for example, are about 50% more likely to deliver prematurely than their white peers. That's a very well-known kind of, fact in the literature. But what we forget about and doesn't get as much attention is that when a Black individual is facing multiple risk factors, what we see is the accumulation of risk can be even more profound. So it's important to have really substantial conversations around risk factors and things that we can do about this, and an actionable framework. What I was saying before around aspirin, knowing a number of individuals on our community advisory board, for example, identify as Black, and they will say, their provider said, you need to take an aspirin because you're Black and pregnant. And then they're surprised maybe that somebody who's, you say had to take it because they're Black and pregnant doesn't take the aspirin. That it's just having those conversations in a respectful way that really is transparent around why this may be helpful, right? Like those are the kind of conversations we hear happen all of the time without really being transparent and respectful in how we talk to people about risk. So yes, we know that because of social factors, individuals who identify as Black are at higher risk for preterm birth, but it's because of social factors. It has nothing to do with their biology.
If you could correct one common misconception about preterm birth, what would it be?
I hands down, and I hear this unfortunately, from researchers and physicians of like, there's nothing we can do about it. By the time somebody's pregnant, things are just what they are. And the data does not show that. And we have to do a better job of giving every person the care that they deserve. And I think if we do, we'll make a difference.
This feels like, as you're sharing, the data is out there that there are things to do, but how does it get in the hands of the care providers? Because we do know that it would say average like 17 years from the evidence-based information being discovered to it being in practice. So I think that's it. I think it's 17 years. But so how this is so important for people to stay up to date on, especially if someone does start to have some of these risk factors. How do we get this so that the care providers are screening it like they'd screen anything else?
Right. Well, they do that now, right? There's a lot of different screening tests where they'll screen for hypertension, or they'll screen for social determinants, or they'll screen, one of the things
but they're not necessarily asking like, how are you sleeping? How's your stress level?
Exactly.
They don't even always check for anemia. Cause I know I can't tell you how many times my students, week after week, I'm tired. I'm like, have you had your iron level checked?
Right.
They're like, no.
Exactly. So we know lots and lots and lots and lots of things are falling through the cracks. So we have to understand those cracks. I will say, like you, I have gotten impatient in this space, which is why, for example, we created Natalie, right? So that Natalie is just a tool for pregnant people. And I'm really lucky that, we'll be starting a randomized controlled trial at NYU in the late spring, working with the Department of Obstetrics and Gynecology to really, in a group of a couple hundred people, determine whether if you have this information using something like Natalie, and you not only identify the risk factors, you communicate about the interventions that may be helpful to them and facilitate that conversation between a pregnant person and a provider, that we will see an uptake in intervention use and better pregnancy outcomes. So we're moving quickly to to not only make sure that we're doing something so that pregnant people understand their risk factors and interventions that may be helpful, but to assist in that communication pathway between pregnant people and providers. So I agree with you. I get very frustrated when, like in the HOPE study, for example, sometimes there's this narrative around people who are pregnant who qualify and should have had a discussion around aspirin not taking it. And sometimes it's like they'll use this horrible term, which is like non-compliance in the pregnant person. But in the HOPE study, we asked pregnant people, did anybody talk to you about aspirin and that it may be helpful to you? And the good news is 70% of those that should have had a conversation with a provider about it did. Right. The vast majority, 80%, then took aspirin. But what happened with the other 30%? Right? Like nobody ever even mentioned it. So you have to kind of understand like what in the world happened here. So those other 30% are not non-compliant. They just didn't. Yeah. Nobody talked to them.
It feels like a lot can be put on the pregnant person's responsibility of like when they go in for their very quick appointments to say something like, I'm not sleeping well, or I'm really stressed. Should I be concerned? And that's a lot of pressure.
How would they know? How would they know? Let alone, some really potent social factors we know are food and housing insecurity, but also, experiencing violence in the home. And if there's not a safe way and also kind of a more routine way to make sure that we have these conversations with people, people may not even realize that these things can be hurtful to not only the mom, but also to the baby. Mm-hmm. And, having those conversations about kind of what stress looks like when it gets under the skin. Mm-hmm. People can understand that. We all know what it feels like when, another one, it kills me, and you'll probably have to cut this out, but, infections during pregnancy and screening for sexually transmitted infections. Antibiotics are miracles.
Oh, we're not going to cut this out. We're going to keep that in there because I want people to know. Why everybody is supposed to get screened for a sexually transmitted infection. Especially because you shouldn't have a vaginal birth if you have active herpes. It needs to be a cesarean. Exactly. So I'm assuming people are getting
or screening for urinary tract infections.
Yes.
God love anybody who's on this call who's never had a UTI, but there's a bunch of people who have UTIs who are non-symptomatic. I have no idea what life is like having UTIs that are non-symptomatic, because mine were always very symptomatic. But antibiotics can make such a big difference. And same thing we see only about half of the people that have a diagnosis that should have an antibiotic prescribed are getting those. And so we have to have, these are very basic conversations, which is like, I understand that you're reluctant to take medication during pregnancy. I completely agree. But this is something that really will respond well to an antibiotic. Mm-hmm. So let's make sure to protect you and baby the best we can, and make sure we at least talk to you about why an antibiotic might be helpful.
This has been helpful. We're going to take one more break. And when we come back, what is one final tip or piece of advice you'd like to offer new and expectant parents? It can come from anything in your mind, wherever you want to go. We'll be right back.
Good sleep is everything. That's why Ollie's Science Bag Support is made with a blend of melatonin and L-theanine for both kiddos and grown-ups. So when your mind won't switch off, you've got something that can help. Your racing thoughts and restless nights won't stand a chance. Find Ollie sleep solutions for the whole family at ollie.com. That's OLLY.com.
All right, so we are back. So what is one final tip or piece of advice you'd like to offer new and expectant parents?
I am such a strong believer in the power of you knowing your own health best, right? And empowerment around healthy pregnancy and healthy outcomes. So, but at the same time, it's so easy to go on Google or whatever and just trying to find whatever you can. So, sticking to really trusted resources that come from sources like, the CDC, Mayo Clinic, hospital systems, essentially to really kind of look at that solid research to better understand the things that truly are risk factors and truly are interventions. And then I think the second thing is to just really, it's so important to have responsive, quality, comfortable prenatal care. And if you don't feel like you're getting that, asking for that, advocating for yourself, switching to a prenatal provider that you feel like is listening to you and treating you with value and respect, that's going to be so important sort of as you move through your journey. I think sometimes people might have things that aren't going well and they don't want to change. They maybe don't want to be rude. But
sometimes their insurance doesn't allow them to change. That happens.
Yeah, absolutely. Absolutely.
And in those cases, I'm going to just throw out my response for that is there's doulas out there that have a wide range of pricing. So especially if I used to be a doula and I'm shocked at how expensive some of them have gotten. But say you're getting for like the high tier, there are, sliding scales. So bring your doula with you, or if you have a partner, bring your partner with you to the appointments. Because I know even when I go to the doctor for my yearly checkup, I have to write questions down or I forget on the spot.
Yeah.
So having someone help
the other
advocate.
part of this is, we know on the East Coast, for example, midwives are so much more common than say on the West Coast, right? And having a midwife, sometimes people think, oh gosh, I want to make sure I have, my MD, et cetera. But, there's a lot of data suggesting that people can often find midwives to be that much more responsive, et cetera. And so, being open for getting the care that feels good and open to you, right? Rather than,
and their appointments are longer. I had a midwife for both my babies, and the appointments would be like 45 minutes, but I started with an OB and it was like 10 minutes.
Exactly. And that's very much an American phenomenon. In talking to my colleagues in Great Britain, for example, and explaining to them that in the U.S., it's an OB that's often providing you with prenatal care, they're very confused because that's always a midwife who's going to do your routine appointments. And then the OB will come in if there's if there's some problem. And we don't do it that way. So being open to these other kinds of care so that you really are feeling like it's a good fit.
Oh, I love that. I love your several pieces of advices. Where can people? No, I'm being totally honest, and I hope that didn't come across as snarky. I was being quite sincere. I thought you had great advice. Where can people find your work?
So, you can always, I have such an unusual last name, Jelliffe-Pawlowski. You can find my work kind of all over the place. But I will point you to our startup, which, the tool that I was talking about, Natalie, which is NATAL.LY. And that's where we're rolling out the tool so that people can better understand their pregnancy risk and learn about it. So we're currently looking for people who can help us vision this. And we welcome anybody who's excited and interested.
Oh, this has been really helpful. You gave some solid information about what to look for, what some of the factors are, what to do. And I'm hoping build people's confidence that they don't just throw their hands up in the air and say, we'll see what happens. So thank you for a really wonderful conversation.
My pleasure. Thank you for having me.
This has been an episode of Yoga, Birth, Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.